All right, good morning. For those of you new to this format, this is a live Teams meeting, which restricts access to visual and auditory commentary to just the presenters. So those of you in the here viewing this, you can reach out to us if you have any questions or concerns at another date. Feel free to email me. First action item for this quarter's QMS is to approve the minutes from the last meeting. Obviously, this is difficult because many of you may not have viewed this prior. But if you reach out to me with objections, we can note those, and if enough object to the minutes, we will bring this up at our next meeting. So I'd like to take an opportunity to introduce the new medical staff members. The medical staff members, historically we would have, if we were all in a room together, we would have you stand and introduce yourselves so people could see you. In this format, unfortunately, that's not possible. So I encourage you to look at these names, and if you identify any of these people in your daily work, please reach out to them and welcome them to Missouri Baptist. The next order of business is physician acknowledgement. Every quarter, we try to identify a physician who has stepped up and performed exceedingly well. This quarter, we'd like to acknowledge Dr. Durer. Dr. Durer is a member of the OBGYN department, and I would like to just share with you something that happened recently. Dr. Durer was informed of a patient with a uterine rupture, which is a critical and life-threatening emergency. This was not one of his patients. This patient was already admitted to the hospital. Rather than disregard the information, Dr. Durer stepped into that void and provided the necessary care to save this patient's life. The patient's attending physician was not immediately available. So on behalf of the MUC and the entire medical staff, I want to thank Dr. Durer for demonstrating what it means to be an exceptional physician at Missouri Baptist. So if you see Dr. Durer, please congratulate him. This was exceptional work on his part. The format for this QMS is a little different than others. We've decided to have brief updates on a number of important topics rather than lengthy presentations of one or two topics. I believe that Dr. Botany is available now to discuss Vizient. Go ahead, Mitch.
Next slide, Alejandro. So I don't know if we can see this really well, but the last time I presented on this, we were a category 3, and we had 3 stars, and we had several deficiencies. And due to everybody's hard work, we've been able to move to the 3 position out of 97 hospitals. So we're ranked 3 overall in our cohort. The biggest improvement was in our mortality score, and I just want to thank everybody because a large part of moving up our mortality rate, we went from about an ODE ratio of over 1.1 down to an ODE ratio of about 0.7. In other words, we're seeing only 70% of expected deaths based on our patient population, and a lot of that has to do with your documentation. So thank you very much. Next slide. And that was where we were before. Nope. And again, we have made significant. This was the one up in the upper right-hand corner was from a year ago, but we actually started with a 3-star rating around 54 in our rank when we first started this journey to improvement. So just thank you very much, everybody, and enjoy your success. This is a huge success. Recognized across the country. So thank you very much.
Thank you, Mitch. Chuck Crecelius is going to update us on some issues regarding TPOP. Chuck, if you're available, if you could take over.
Sure. Can I have the next slide? TPOP, as we brought up before, is an advanced directive and a physician order in the hospital. Basically, we have that in our order set, full, limited, and no code status. But when people leave hospitals, they become nothing. Their code status disappears under current Missouri law. Right now, we have an out-of-hospital DNR, OHDNR form, the purple form. It only has no and full code, requires a competent person to sign it. It doesn't have the all-important limited code that a lot of our palliative care patients need. TPOP matches that hospital code status format. Next slide. Standardized TPOP form is shown here. It's fairly straightforward. I'm not going to go into detail, but it's basically, do you do CPR? What particular interventions do you do if you are not a CPR? And then what about nutrition if you can't eat? Next slide. So basically, who should have a TPOP form? It's typically designed for people in the last year of life, chronic, frail people. Some people with a very strong preference, and for PCPs and specialists alike, the surprise question pretty well tells you whether you need a TPOP. Would you be surprised if this patient died within the next year? If the answer to that is no, then you probably should be discussing advanced directives in TPOP. Next slide. So TPOP's an integral part of improving our palliative care and DNR's status outside the hospital. There's legislation in place now indemnifying providers using TPOP. There's a little delay. As of Friday afternoon, we found out DHSS may modify the form somewhat. So let's see, I'm getting an echo, sorry. Right now, Missouri Baptist Hospital is actually among the best in the BJC system in hospital code status. We do a very good job of getting a code status in the hospital. The trouble is we don't always make certain it falls a patient upon discharge. Hospitals right now are giving their statistics on when they transfer people out of the hospital where their TPOP was completed. We will also be doing this with PCPs down the road, and we're going to be encouraging, at least as a medical group, this same effort to make sure people's advanced directives are well known. Next slide. So BJC itself is developing a large effort in this area. We know palliative care reduces cost, improves patient satisfaction. The palliative care clinical program is one of the first system-wide groups. Essentially, every clinical program throughout the BJC system will be involved in a clinical program. Palliative care was one of the first. Our med group now has a new MLA module, end of life risk management ethics. If you're like me and procrastinate and haven't done all of your MLA training, consider using this module. I think it's pretty good. The reviews of it so far have been very good. The medical group also has a lot of machine learning methods for identifying best patient candidates for palliative care we're going to be coming out with. So helping you find those people that do need a TPOP and then incentivizing you to do it will happen. Palliative care TPOP is part of our motto of cure when able, care always. It is not giving up. It is not just shifting the ball to the palliative care people. It's caring about the patient throughout their life. That should be all. So thank you very much, Chris, for allowing me this time.
This is a very important topic, and I'm glad to hear that Missouri Baptist is doing well in addressing code status. Next, a very topical topic. I've asked Rhonda Cook to discuss the current state of COVID testing, which I think many of you will have interest in. Go ahead, Rhonda.
Thank you, Chris. Next slide, Alejandra. I speak to physicians daily and hear their frustration with COVID testing. Who could have expected that so long after the identification of the novel coronavirus, we still would not have rapid testing for all patients? I wish that I could provide every patient a rapid PCR test, but BJC doesn't have sufficient supplies to make that happen. As some of you have heard me explain before, our laboratories are limited by the allocation of tests from our vendors, and that is the reason we have so many testing platforms in use at Missouri Baptist and within BJC. No single platform can meet all of our testing demands, so BJC is using multiple platforms for different patient populations. In the past couple of months, we have exceeded our testing capacity within our system several days a week. And for that reason, on October 28th, we will have a completely new antigen test go live at Missouri Baptist and across our system. Next slide. The antigen test is not as sensitive as PCR testing, but we will use it to test our urgent pre-procedural patients and those being released to congregate care facilities. The antigen test is currently completing validation at Missouri Baptist for both nasopharyngeal and oropharyngeal swab specimens and will be performed at all BJC laboratories. Our PCR platforms will continue to be used for symptomatic patients and pre-procedural patients whose procedures are scheduled ahead of time. Next slide. Within the category of PCR testing, BJC is running 4 different platforms. At Missouri Baptist, we have the rapid COVID-only test from Cepheid and the BioFire Respiratory Panel 2.1. BJC will receive no further shipments of the COVID-only test cartridges from Cepheid. About 2 weeks ago, on September 26th, Cepheid received emergency use authorization from the FDA for their 4-in-1 test, which includes influenza A, influenza B, RSV, and COVID. All Cepheid manufacturing capacity is now devoted to the 4-in-1 test, and we hope to receive validation kits soon. Cepheid has only allocated BJC the same number of tests that we used during last year's mild flu season, a very modest number. So we cannot begin to use this test until influenza begins circulating in our community, or we run the risk of exhausting our supplies before the end of flu season. In the same way as Cepheid, BioFire has sharply limited the number of tests that they will provide to BJC within the upcoming months, so their rapid test is also in extremely short supply. RP 2.1 has 22 targets, both viral and bacterial. It must be reserved for admitted patients who require bed placement and certain immunocompromised patients. Downtown at BJH, we continue to have batch testing that is performed on the Roche and MID platforms, which are providing the bulk of BJC's COVID-only testing. In the most recent data from last week, 95% of the COVID testing performed on the Roche platform was completed in less than 26 hours. The COVID testing algorithm for patients has been developed by BJC Incident Command and the Center for Clinical Excellence. Next slide. As of 10/9/2020, this is off the topic of testing, but Missouri Baptist has transfused 84 patients with convalescent plasma provided by the American Red Cross. We have a significant shortage of this valuable product. If you know of anyone who has recovered from COVID, please ask them to donate convalescent plasma. If they're not sure whether they have been exposed, for a limited time, all blood donors at the American Red Cross will be tested for COVID antibodies, and if present, those donors will be recruited for convalescent plasma donation. Thank you.
I was remiss earlier in that I did not share with the audience that if you have questions, at the bottom of your page, there is a link. Questions there. We will ask them of the presenters. Rhonda, we do have a question, and the question is, will the hospital be testing all patients discharged to nursing homes and assisted living regardless of diagnosis? And will other BJC hospitals do the same? Can you comment?
I think the answer to that is yes, simply because most of these facilities are requiring that testing prior to transfer. I do believe it would be up to the congregate care facility, though.
So for the audience members, please enter any questions you may have, and I will ask those of the presenters. Next, we have Nitin Anand, who's going to give us a clinical COVID update for the hospital. Nitin, it's yours.
Thanks, Chris. So since the pandemic began in earnest in March, we've had a number of successes at Missouri Baptist. The most notable for me has been that our staff has been kept relatively safe. We still haven't had a single frontline ICU nurse who's been exposed at Missouri Baptist, and I think part of that is because we've really focused on safety. We have an adequate supply of personalized protective equipment now, and we really haven't talked about any shortages over the last few months. We're approaching 10,000 positive coronavirus cases at BJC, and of those we've had less than 500 deaths, and most of those happened a few months ago or early on in the pandemic. Everyone asks me how we're doing. Our BJC census, it peaked at about 100 early on in March or April. Sorry, that's the ICU population. And since that point, we've been running like in the 30, 40 to 50 range. This is a snapshot from last week. We had 150 patients hospitalized in BJC. 50 of those were in the ICU, and 22 of those were in the ICU and on a ventilator. Missouri Baptist has been taking care of about a fifth of the BJC patients, but we've been taking care of a higher proportion of the critically ill patients, maybe a third of the BJC patients. And this is the St. Louis epi curve. So these are total coronavirus cases. So you can see that the number of cases has really gone up in the last few months. And I think that's really a testament to the earlier detection, the increased community awareness, and more testing. Because as you can see from the next slide, our inpatient census was actually highest in March and April. So I think that's a result of not everyone was being tested in March and April. Whereas now, now the curve is kind of flattened out. So as we're testing more, we haven't necessarily seen our inpatient census go up. So with regards to, and I think part of our improved mortality is a selection bias. It's the population that we're seeing. We're seeing a healthier population that's hospitalized. But some of it's definitely has to do with our therapeutics. So our care of these patients has really evolved, and it's improved as we've become more experienced and older. So the therapeutics that we have, we're really using all 3 of these agents on all hospitalized patients requiring oxygen. I haven't had a single one of my patients decline one of those interventions. They usually want everything we can throw at them. We're using Decadron, which was shown in a randomized study from England to improve 28-day mortality. Remdesivir, which from the ACT trial was shown to decrease time to recovery. As Rhonda mentioned, we're using convalescent plasma. And the last area that we're focusing on are a lot of immunomodulatory therapies, which are still being tested, but there's a lot of interest in that area. We're part of some clinical trials which are investigating those. Really, David Stryker and Ken Remy are leading those efforts. Currently, we're enrolling someone in patients in an IL-7 study, which actually enhances the immune response in patients who are lymphopenic. You know, I think we've had a number of successes with COVID, and we're going to continue treating these patients the best we can until we get a vaccine. Thank you.